We're now going to begin physical examination of the abdomen. Physical examination begins with inspection. You look at the abdomen. You divide the abdomen into 4 quarters, starting from the xiphoid process to the symphysis pubis and across the umbilicus. You look in all 4 areas, and you're noticing whether or not you see any rashes, scars, masses, any pulsations. Once you've finished inspection of the abdomen, you will move to auscultation of the abdomen. When you auscultate, you will take your stethoscope. Since bile sounds are high sounds, you will use the diaphragm of your stethoscope, and you will move your stethoscope into the 4 planes described earlier, listening for 5 to 34 clicks and gurgles per minute. It's important that you not only notice number, that you also notice pitch. High-pitched, high-frequency bowel sounds would be associated with an early intestinal obstruction. You will note if bowel sounds are absent, if they are hypoactive, less than 5, hyperactive, greater than 34, or again, high-pitched and hyperactive. The other area that you want to auscultate is you want to auscultate the vasculature. Recall that we are listening for bruits, which means turbulent blood flow. We will start by auscultating the aorta. Remember that the aorta lies left to the central plane of the body, and after the umbilicus, it'll divide into the right and left iliacs. You will listen again for any bruits in that area, as well as the femoral area. Any patient that is admitted also needs to be assessed for renal arteries. And the renal artery bruits, again, would be important, particularly in somebody just admitted with new onset hypertension. Once we finish auscultating, we need to move to palpation. For palpation, we're going to do soft palpation to begin with. We're simply using one hand, softly assessing the abdomen, noticing whether or not there's any tenderness, whether or not you feel any masses, etc. Then we can move to deep palpation. Notice in deep palpation, I'm going to use 2 hands to go down and again, feel to feel if I feel any masses or feel any organs, as I will, for example, in the right upper quadrant. Since I'm palpating now, it makes sense that I would palpate the aorta. You're going to put your hand again in the left of the median of the body, and you're going to feel for a pulsation. When you feel that pulsation, you're going to put one finger on one side of the pulsation, the other finger feeling on the other side of the pulsation, and you're going to measure that. And typically the aorta should not be greater than 2 centimeters. While we're here, we might as well feel for femoral pulsations as well in the abdominal area. Related to palpation, again, keeping in mind the liver is always above this costal margin, I want you to put your hand in the right costal margin, and what we can do is we can have the patient take a deep breath. Recall, when you take a deep breath, the diaphragm will move down. It will push the liver potentially against your finger. Additionally, if I keep my hand right here in the right costal plane, mid-clavicular line, if the patient's gallbladder was enlarged, inflamed, had its stones in it, when I asked the patient to take a deep breath and that gallbladder came down and hit my finger because it was enlarged, the patient would complain of pain. That's called the positive Murphy sign and is associated with gallbladder disease. We move from palpation then to percussion. So percussion is again me putting a sound into the body and listening for the sound to come back. I will start up in the chest area, typically at the 3rd intercostal space. Recall the angle of Louis was your mark for the 2nd rib, 2nd intercostal space. Staying in the mid-clavicular line, finding the intercostal space, I will tap. Notice my hand is off the body. My pleximeter finger is simply pushed in, and I am listening for the sound. That's resonance. I move down until the sound changes. When the sound changes to dullness, I make a mental note of that. Now I move down to the abdomen. And in the abdomen, I listen to the sound. That sound is tympany. Staying in the same midclavicular plane, I work my way up until I hear the tympany change to dullness. And then I measure the span of the liver, which should be 6 to 12 centimeters in the midclavicular line, or in the on the sternal line, it should be 4 to 8 centimeters. Finally, to percuss the spleen, recall that the spleen is palpable only when it's at least 2 sizes larger than it's supposed to be. So what we're going to do is we're going to find the 11th intercostal space, and I try to stay in the anterior axillary line, and I tap. And tympany should dominate here, not dullness. And I have the patient inhale and exhale as I keep tapping, and there should be no change. Tympany should dominate there. If it was dullness there, then that dullness is going to be associated with an enlarged spleen. That point is called Castile's point. You again percuss the abdomen. The abdomen should sound tympany in all quadrants. If I heard dullness, then that means there's something solid underneath. If it's a pregnant woman, it's a baby. If it was someone that had liver disease, they develop fluid, which we call ascites, in the abdominal area, and then you have what we call shifting dullness to tympany. Meaning, if I had fluid in the abdomen, the fluid would go off to the side. Therefore, when I tap the patient, it would be tympany until I hit the side, and then it would be dull. So tympany, 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 dullness. Turn the patient on their side, the water would flow to the other direction, and you would have shifting tympany versus dullness.